Hello everyone, my name is Dr. Akash Ganguly, and today my topic is suture materials and suturing techniques. First, the content. I will begin with the introduction, then the goals of suturing, suture characteristics, armamentarium of suturing, suture materials, wound healing phases, principles of suturing, suturing techniques, surgical knot, then the removal of suture, reasons for failure of suture, possible complications, some special regions like the eyelid and the lips, alternatives to suture, presenting one of my cases, and finally the references. First, the introduction. What is a suture? A suture is a stitch or series of stitches made to secure the apposition of the edges of a surgical or traumatic wound. What is suture material? Suture materials are used to keep the wounds together until they hold sufficiently well by themselves by natural fiber, that is collagen, which is synthesized and woven into a stronger scar. The goals of suturing. These include the wound edge apposition, provide adequate tension, maintain hemostasis, aid in wound healing, avoid wound infection, and produce aesthetically pleasing scar by approximating skin edges. HALSTED'S principles of surgery. Well, William Stewart Halsted was an eminent surgeon of the 19th century. He had his work in fields like anesthesia as well as surgery. He gave many new techniques of surgery. The HALSTED'S principles of surgery are as follows: gentle tissue handling, control of hemorrhage, preservation of the blood supply, maintaining strict asepsis, minimizing the tissue tension, accurate tissue apposition, elimination of the dead space, and also the importance of rest. Coming to suture characteristics, we have two types of sutures mainly, monofilament and multifilament. The monofilament suture is smooth and it tends to slide through the tissues easily. It is difficult to knot and can be damaged by gripping it with a needle holder or forceps. This can lead to the fracture of the suture materials. But the multifilament sutures are easy to knot. They have a greater surface area than the monofilaments. They have capillary actions where bacteria may lodge and be responsible for persistent infections. The material can be coated with silicone in order to make it smooth. This image shows the monofilament as well as the braided form of multifilament sutures. Now, suture characteristics. Well, I will be discussing about three properties of sutures: tensile strength, absorbability, and the biological behavior. Coming to tensile strength, well, it can be expressed as the force required to break it when pulling the two ends apart. It depends upon the constituent of suture materials, thickness, as well as how it is handled in the tissues. Coming to absorbability, the suture materials may be absorbable or non-absorbable. This property must be taken into consideration when choosing suture materials for specific wound closure. The oral mucosa and deep structures need absorbable suture material, whereas the vascular anastomosis need non-absorbable suture materials. Coming to biological behavior, it is the response of the body to the suture material, how our body reacts or responds to the suture materials. It depends upon the constituent of the raw materials. Now, the armamentarium of suturing. For suturing, we require a suture needle as well as suture materials. The needle holder, it has the following parts: the jaws, the joint, shank, rings, rashing. How do we hold it? For this, we use a thumb as well as the ring finger and insert these fingers into the rings. Use the index finger to stabilize the needle holder. Now, the suture needle, it is made up of either stainless steel or carbon steel. It has the following parts: the point, body, and the end. Now we move on to classify this needle. It can be classified according to shape as straight or curved, according to eye as eyed needle or traumatic, eyeless or atraumatic. According to the cutting edge, it can be round body or cutting body. The cutting body is further divided into the conventional and reverse cutting needle. According to its tip, it is divided into the triangular, round, and blunt. In this image, you can see the 5/8 circle, the half circle, 3/8 circle, 1/4 circle, and J needle, as well as the straight needle. These different types of needles have uses in different spheres of surgery. What is important here is to focus on this conventional cutting and reverse cutting. In conventional cutting, it has a triangular body that offers a third cutting edge on the inside concave curvature, whereas the third cutting edge is on the outside convex curvature in the reverse cutting needles. For the oral and maxillofacial surgeons, as well as doctors who work on the oral cavity, for the closure of oral mucosal incisions, it is usually the small half circle or the 3/8 circle suture needle that are used. The advantages include that this needle is curved and it allows it to pass through a limited space that a straight needle cannot reach. And this passage can be done with the rotation of the wrist. Suture materials, the ideal properties. It should be easy to handle, have a predictable behavior in tissues, predictable tensile strength, be sterile, have a secure knotting ability, minimal tissue reaction, as well as non-allergic, non-carcinogenic, and have a non-shrinkage property. Classifying the suture material according to the source, it can be natural, synthetic, or metallic. According to fate, it is either absorbable or non-absorbable. According to structure, it is either monofilament or multifilament. According to the coating, it can be coated or uncoated. In natural, we have the absorbable, which include the catgut, chromic catgut, collagen, fascia lata, and beef tendon. In non-absorbable, we have the silk, silkworm gut, linen, cotton, and ramie. In synthetic, we have absorbable, which includes the polyglycolic acid, polygalactic acid, polygalactine, polydioxanone. And in non-absorbable, we have the nylon, polypropylene, polyesters, and polyethylene. The metallic ones are stainless steel, tantalum, silver, gold, aluminium. In monofilament, again, it is divided into absorbable and non-absorbable. The absorbable ones are catgut, chromic catgut, Vicryl, and PDS. In non-absorbable, we have polypropylene, polyester, nylon, polyvinylene fluoride, polyvinylidene fluoride. In multifilament, we have absorbable, which include the Vicryl and polyglycolic acid, and non-absorbable, which are the silk, cotton, and linen. Now, the difference between monofilament and multifilament sutures. The monofilament have no capillary action. The multifilament has capillary action. There is less infection risk in monofilament sutures, whereas there is increased infection risk in the multifilament sutures, since the bacteria get lodged in between the spaces of these sutures, this braided form of sutures, and may lead to persistent infections. Smooth tissue passage is offered by monofilament sutures. The passage is less smooth for the multifilament sutures. The monofilament sutures have a higher tensile strength, whereas the multifilament ones have a less tensile strength. More throws are required in the monofilament sutures, whereas the knot security is better in the multifilament sutures. Coming to the fate of the suture materials, in absorbable, these are degraded by the enzymes. There is hydrolysis or phagocytosis. These absorbable ones are used to hold the edges in approximation temporarily until the wound is healed. In non-absorbable, we have encapsulation or walling off by the fibrosis. It is used to suture at sites where tensile strength needs to be maintained. Now, coming to the selection of these materials, this depends on the condition of the wound, the tissues to be repaired, the tensile strength, the knot holding characteristics, and the reaction of surrounding tissues. Now we'll talk about few of the suture materials. First, we will discuss about the plain and the chromic catgut. What is important here is that the plain catgut loses half its strength by 5 to 7 days, whereas the chromic catgut loses half its strength in 17 to 21 days. The effective strength is lost in about 15 days in the plain catgut, whereas the effective strength is lost in about 30 days in the chromic catgut. Because of its antigenicity, it provokes a lot of tissue reaction in the plain catgut sutures. In chromic catgut, well, these can be used in all tissues where prolonged approximation is not necessary for healing. There is less tissue reaction than with plain catgut. Commonly used suture materials. We have the polypropylene, Prolene. Well, this is a synthetic non-absorbable suture material. It is a polymer of propylene. Its uses include in general surgery, plastic surgery, cardiovascular surgery, and skin closure. The advantages are that it won't lose its tensile strength over time. It has a good knot security. It has very little tissue reaction and high plasticity. The disadvantages are it gets stretched when pulled. And one of the major disadvantages is that it loosens when the edema subsides. Now coming to silk. Well, it is a natural non-absorbable multifilament suture material. It is made from the filament spun by the silkworm larva. Its uses are in ophthalmic, general, and plastic surgery. Its advantages are ease of handling, good knot security, and cost effectiveness. The disadvantages are that it is very reactive and can't be used in the presence of infection. Coming to Vicryl, it is synthetic and absorbable suture material. It may be monofilament or multifilament, and coated or uncoated. It is available in purple color or undyed form. It is used in intraoral suturing as well as gut anastomosis. The advantages are that there is minimum tissue reactivity. It can be used in infected tissues. It is stronger than gut and retains its strength for 3 weeks. The disadvantages include, in case of prolonged approximation, it can't be used. There is delayed absorption and increased inflammation when we use Vicryl. The use of different types of suture: in face, we have 5-0 to 6-0. In scalp, we have 3-0 to 5-0. On chest, 3-0 to 4-0. And back, 3-0 to 4-0. Again, abdomen, the same, 3-0 to 4-0. In extremities, 4-0 to 5-0. And in joints, 3-0 to 4-0. Coming to the biological response to suture materials, the fate of suture materials. The early response is a generalized acute aseptic inflammation where the primary polymorphonuclear leukocytes are involved. After a few days, the mononuclear cells like the fibroblasts and histiocytes are involved, and then there is capillary formation at the end of initial phase. Coming to the phases of wound healing, these include the initial lag phase for the first 5 days. In this, there is no gain in wound strength, and the wound is dependent on the sutures and epidermal cellular adhesion to maintain the closure. In fibroblastic phase, it is from day 5 to day 15. There is rapid increase in wound strength. And finally, the maturation phase, which is day 14 and beyond, where there is further connective tissue remodeling. This image shows the different phases of wound healing. The points to note here are that when most skin sutures are removed, only about 3 to 7% of the final tensile strength is achieved. By the end of 3 weeks, only 20% tensile strength is achieved. By the end of 1 month, about 50% is present, and wounds never regain more than 80% of strength of intact skin. Coming to the biological response of suture materials, which I have dealt earlier in my slides, we have the natural absorbable. In this, we have proteolytic degradation, and the tissue response is intense. In synthetic absorbable, there is hydrolysis as well as less intense response. In non-absorbable, there is encapsulation and acellular response. Coming to the principles of suturing, the needle should be grasped at approximately 1/3 of the distance from the eye and 2/3 from the point. It should enter the tissue perpendicular to the tissue surface. It should be passed along the curve. The suture should be passed at an equal depth and distance from the incision on both sides. The needle should pass from movable to the fixed tissue. The needle always passes from thinner to the thicker tissue. The needle always passes from deeper to superficial tissue. The tissue must never be closed under tension. The knot should never lie on the incision line. The suture should be placed at a greater depth from the incision line so as to evert the wound margins. A very important point here is that the sutures on the skin are usually removed in 5 days. The intraoral sutures are removed in 7 days. And when there is tension while suturing, which should be avoided, but whenever it is present, the sutures may be kept for 10 days. Coming to the suturing techniques, we have the interrupted suture, continuous suture, mattress suture, figure of 8 suture, and subcuticular suture. We will also be delving deep into two different types of suture, like the purse string, in my further slides. Coming to the simple interrupted suture, its uses include closure of the wound after single tooth extraction or third molar extraction, biopsy, and implants. Advantages are that it is simple, it is performed in urgent situations, and easy to remove. The disadvantages are that it fails to bring all the surfaces in contact. The technique for interrupted sutures. First, there is cleansing and debridement. It is the most important step initially. Then we select the appropriate suture. The wound margins are accurately apposed. The suture needle is held with the needle holder positioned at least 1/3 the length of the suture away from the end of the suture attachment that was described in the principles of suturing. A bite of skin is taken at a landmark site. The needle is advanced to the depth of the wound margin and then through the wound opening. The needle is next inserted by the depth of wound and rotated through the opposite skin margin at the landmark site for the apposition of the wound. This is a video showing the simple interrupted suture.
Interrupted suture. Starts at 90 degrees, moves somewhat outwards as it follows the curvature of the needle, exits on the contralateral side of the wound in a similar fashion. Pulled through gently. And gently tied.
Suture material is tied. After we enter it at 90 degrees, the knot is placed on either side of the incision line, not on the incision line. Then we cut the ends as short as possible to avoid foreign body reaction. Then coming to continuous suture, these are of three types: the simple continuous, locking continuous, continuous over and over suture. In simple continuous, we have the following use. In well-approximated wounds with minimal tension, the advantages include rapid technique for closure. Disadvantages are that it shouldn't be used in areas of existing tension. It is not possible to free a few sutures at a time, and when one suture breaks, it affects all. The simple continuous suture. The beginning of the simple continuous suture is similar to the simple interrupted suture. The needle is then inserted in a continuous fashion such that the suture passes perpendicular to the incision line. This is ended by passing a square knot over the untightened end of the suture. This is an image for the simple continuous suture. Now the locking continuous sutures. Its uses include long edentulous areas, tuberosities, retromolar areas. The advantages are that it avoids the multiple knot of the interrupted suture. The technique: at first, a single interrupted suture is used to make a tie. The needle is inserted through the underlying surface of the flap. It is then passed through the remaining loop of the suture, and the suture is pulled tightly, thus locking it, hence the name. This procedure is continued until the final suture is tied off at the terminal end. This is an image of the locking continuous suture. Now the continuous over and over suture. Initially, we give a simple interrupted suture, and the needle is reinserted in a continuous fashion such that the suture passes perpendicular to the incision line below and obliquely above. The suture is ended by passing a knot over the untightened end of the suture. It provides a rapid technique for closure and distributes the tension uniformly over the suture line. This is an image. Now coming to the layered closure. Wounds that involve only the skin are best closed with a single layer of interrupted suture. In case of deep wounds, tissue should be closed in layers to remove the dead space and confer strength to the wound. The technique for layered closure involves closing the deeper tissues first using a continuous sutures and then closing the skin with interrupted sutures. The mattress sutures, it is of two types, horizontal and vertical. The horizontal mattress suture is used in intraoral bone grafting and closure of extraction socket. The advantages include providing a broad contact of the wound margin and providing a watertight closure. The disadvantage is that if it is improperly used, there may be bone necrosis and dehiscence, which may occur due to limited blood supply. Coming to the technique of the horizontal mattress, it is inserted, it is passed from one edge of the incision to another and again from the latter edge to the first edge in a horizontal manner, and the knot is tied. The distance of the needle penetration from the incisor line and the depth penetration is same for each entry point. The horizontal distance of the points of penetration on the same side of the flap differs. That is, the needle penetration through the surgical flap should be at least 8 mm from the flap edge. This procedure is continued till the entire length of the incision and the knot is tied. This is an image for the horizontal mattress suture. Now the vertical mattress, it is similar to the horizontal mattress except the depth of penetration, that is, when the needle is brought back from the second flap to the first, the depth of penetration is more superficial. It is used in closing deep wounds of the abdomen or hip. Advantages are that it decreases the dead space and provides increased strength. It doesn't interfere with healing. The disadvantages are that in this approximation is difficult. Here is an image for the vertical mattress suture. The figure of 8, it is the most commonly used for extraction socket closure as well as the adaptation of gingival surface papilla around the tooth. The needle first inserted into the outer surface of the buccal flap and then the lingual flap. Suturing begins on the buccal surface 3 to 4 mm from the tip of papilla. The figure of 8, well, the needle should be inserted in the same fashion at a horizontal distance and both the ends are tied. Its advantages are rapid closure. Disadvantages are that due to its orientation, it is difficult to remove and it may leave significant amount of the suture material within the socket. Here is an image for the figure of 8 suture. Coming to the subcuticular suture, it is usually a running stitch but can be interrupted. In this, we give intradermal horizontal bites, allow the suture to remain for a longer period of time without development of cross-hatch scarring. Its uses are simple, uncomplicated wounds. Advantages are excellent cosmetic closure and no stitch to remove since it is within the defect. Disadvantages are that it is technically more difficult to master and doesn't hold in thin skin. This is the image. Now coming to the purse string suture. It is defined as a surgical suture that is passed as a running stitch in and out along the edges of a circular wound in such a way that when the ends of the suture are pulled or drawn tight, the wound is closed like a purse, hence the name. It is frequently used in closure of cutaneous defects with satisfactory healing and cosmetic results. Application of this suturing technique in the oral cavity has not been reported. However, in one journal, I came across the double layer technique for the closure of oronasal communication. In this, a purse string suture was used with 3-0 round body polygalactin suture, then which provided a barrier between the oral cavity and the nasal cavity. And after this, a contralateral pedicled palatal rotation axial flap was given. In this image, you can see that how this purse string suture was given by pulling the ends, tightening it, and closing the defect just like a purse. This is the image of an area where the purse string suture was used initially, and then the contralateral palatal pedicle palatal flap was used. Now the far, near, and far, near, far suture techniques. It is an overlapping suture pattern. It provides extra strength but requires extra suture material as well. The advantages are that it is a good tension suture. Disadvantages is that it is a time-consuming suture. Surgical knot, as described in this image, we have 3 parts of a knot: the loop, the knot itself, as well as the ears, which are the cut ends of the suture. Coming to the principles of knot tying, we should use the simplest knot that will prevent slippage, tying the knot as small as possible and cutting the ends of the suture as short to minimize the foreign body reaction. Avoiding friction or sawing, avoid excessive tension. Tying the sutures too tightly may strangulate the tissues. Maintenance of traction at one end of the suture after the first loop is thrown. Placing the final throw as horizontally as possible to keep the knot flat. Limiting the extra throws to the knot as they don't add strength to the properly tied knot. Different types of knots are the secure or square knot, surgeon's knot, granny's knot, or slip knot. Square knot. The first throw is placed in precise position for the knot using a double loop. The second throw is tied using horizontal tension. Additionally, 2 throws are desirable. Additional 2 throws are desirable in this step. So there are in total 4 throws. In the surgeon's knot, we follow the A-B pattern, that is, formed by 2 throws in the first tie and then 1 throw in the opposite direction in the second tie. It is recommended for tying polyester suture materials such as Vicryl and Merceline. In Granny's knot, a tie is given in one direction, followed by a tie in the same direction, and a third tie in the opposite direction to square the knot and hold it permanently. Here we follow the AAB pattern. It is used in silk, plain or chromic catgut. Coming to the removal of suture, first the area is cleaned with normal saline. It is grasped, the suture is grasped with a non-tooth dissecting forceps and lifted above the epithelial surface. Scissors are then placed through one loop and then transected as close to the surface to avoid dragging the contaminated suture material through the tissues. The suture is then pulled towards the incision line to prevent the dehiscence. If suture is entrapped in scab, the application of peroxide is important to dissolve this part. Now, something important to note here is that if pieces of suture are left, infection may occur. What are the reasons for the failure of sutures? It includes breakage, cutouts, knot slips, and extruded suture. Some possible complications of leaving the sutures for many days include sutural abscess or scar or stitch mark. This image shows the correct method of suturing technique, how it is done and how it should be. In the A figure, in the B, we have unequal spacing, which is not recommended. Excessive tension is not recommended also. Now we can also have skin inversion and skin overlap. These should also be avoided. Some alternate to suture materials. This includes staples, tissue adhesives like cyanoacrylate, and tape. Now coming to the eyelid and lips, some special regions on how suturing should be done in these areas. For eyelids, it presents a unique challenge to the surgeon. The dermis is very thin with a near absence of subcutaneous fat in some areas. The highly elastic eyelid skin also means that the disfiguring residual pull is possible, so ectropion, that is the pulling of the eyelid away, is the most extreme outcome along a spectrum of lid pull abnormalities. Suture material used in eyelid repair is 5060 braided or monofilament suture material. When transepidermal sutures are used, 6070 monofilament is often the best. Using fast absorbing gut suture or the newer rapidly absorbing synthetic sutures, we can close this eyelid region. Standard approaches include the setback dermal suture and the buried vertical mattress technique. Transepidermal evertic techniques, such as the running horizontal mattress or running diagonal mattress, may be used. Finally, we give the frost suture, which may be used to mitigate the risk of developing ectropion due to tissue edema in the immediate postoperative period. Here is an image showing the various types of suturing techniques that we can use in the eyelid region, which include the simple running suture, buried vertical mattress, setback dermal suture, simple interrupted suture, and depth correcting suture, simple interrupted suture. Coming to the lips, what is important in closing the lip defects is that the approximation of the vermilion border, which is of extreme aesthetic importance. Suture material 5060 absorbable braided or monofilament suture materials is often used on the lips. It is approached in layered fashion. Absorbable suture may be used for both muscle and dermal repairs. Transepidermal approaches should be used with caution on the lip because of the rich vasculature of this region. 6070 non-absorbable sutures are generally appropriate. Standard buried dermal techniques such as the setback dermal and buried vertical mattress approaches can also be used. Buried vertical mattress was also used in the eyelid region. Simple interrupted sutures and depth correcting simple interrupted may also be useful when fine-tuning the approximation of the lip margin. This is an image showing the various suturing techniques for closing the lip region, which include the simple running suture, buried vertical mattress, tip stitch, simple interrupted suture. This is one of the images that I had taken care of in the casualty. This patient came with this type of defect. I had closed it in 2 layers using the simple interrupted suture. And finally, this image showing the healing after 7 days when we remove the suture material. Recent advancements. Well, recent development of self-healing sutures that release drugs that enhance the healing process without interfering with the characteristics of suture, properties of suture like the tensile strength, have come up. Well, delivery of anesthetics, analgesics, anti-inflammatory agents, or antibiotics from the sutures directly into the wound site has been seen. Polymers used to create biocompatible and reliable drug delivery devices have also come up. Sutures may also carry protein and stem cells to the disease site. Nowadays, triclosan coated sutures have also come up, but it has faced some resistance in the recent past. The silver nanoparticle coated sutures have also been found to have good antimicrobial properties. These are my references. Thank you.